Great. Hi, everyone. You have joined us for Mountain States Regional Genetics Network's Time for Genetics, Cerebral Palsy Family Perspectives call. Thank you all for joining us today on March 13th, and we are excited to have two family guests joining us today to share their stories. I just always start off with our HRSA statement. Mountain States Regional Genetics Network is funded by a federal grant from Health Resources and Services Administration and part of HHS. And if you have any questions about this grant funding, you can contact hrsa.gov. I am Christy Weiss. I'm the projects manager for Mountain States Regional Genetics Network, and I am excited to be your host today and head up the Time for Genetics program for Mountain States. It's been a real pleasure to be able to work with all the primary care providers and pediatricians that join us for this Time for Genetics initiative. This initiative is our pediatric primary care genetics education interview. Yep, hi there, welcome. And so we have in our 8-state region, we have 2 cohorts currently joining us, cohort 1 and 2, and we have 18 of those clinics, which you can see in the yellow and orange dots there on the map. And we are really excited to be having cohort 3 join us in April, when we will begin our next topic area for newborn screening. So if you happen to know of any colleagues for those clinics that are on the call today that would like to join us for cohort 3, we are doing our kickoff call next week. So if they are able to, if you're able to have them let me know that they're interested and they'd like to sign the partnership agreement, we're able to get them in that cohort 3. We have a couple spots remaining. So if you know of a pediatric practice that would like to join us, please let me know sooner rather than later, because we will be kicking off cohort 3 with our kickoff call next week, and then they'll be joining us in April for our newborn screening topic area. And you can see the cohort 3s there in blue. With that, I am excited to introduce you all to 2 wonderful families that I've gotten to meet in the last couple of weeks. Jen from Colorado and Aaron from California. And though California is not part of the Mountain States region, I was very pleased to get to meet Aaron through a connection of a family that I knew in Texas in our region. So we're pleased to have him joining us from the West Coast today. With that, I'm going to turn it over to Jenny to share some of her story. And then after she's done talking, Aaron will share some of his family story. And then we will have some time at the end for some questions and answers and discussions. So with that, I'm going to stop sharing my screen so that you can see Jenny there. And Jenny, I'm going to spotlight you so that you can, everyone can see you. There you go. I'll turn it over to you. So you please share some of your journey with us.
All righty. Hi, I'm Jenni Fautsko. We live in Glenwood Springs, Colorado, on the western slope of Colorado. We have a 13-year-old amazing son, Turner, that lives with a rare genetic condition called CAND, K-A-N-D, KIF1A associated neurological disorder. So he has a mutation on his KIF1A gene. So our journey with Turner and kind of from a CP genetics lens, I had a pediatric family doctor that I'm a researcher, so I researched a lot to pick who I thought was our perfect doctor for our baby. Turner was our first child, our only child. About 10 months old, I was in an appointment, well check, or I'm not sure what they call that, it's been so long now. You know, one of the milestone checks, I guess, with Turner. He was about 10 months old. I was by myself. I, kind of felt like I knew what I was doing at this point, but since he was 10 months old, it was probably one of the worst experiences I've had in my life with Turner, with doctor's appointments. The doctor said something's wrong, and started comparing Turner to his child that was about the same age and telling me the differences. It was terrible. I felt like I had been punched in the stomach. He threw out the term CP. cerebral palsy, which at that time I had no idea what that meant. And so from there moved on to a pediatric partners here in Glenwood Springs. And that experience was a little bit better, but not much. Basically kind of nobody gave me information on what was going on. From there, we did a lot of testing in our local hospital, which was all very scary with a newborn. He was 10 months old. And then finally got referred to Children's Hospital in Denver, which experiences were a lot better. But with that first doctor, I actually went back to him later and told him how terrible it was. And that, one of my biggest advice would be not to throw out diagnosis when you don't know. You don't know what's going on, just kind of explain things. No one explained anything to us really at all. Even kind of Children's Hospital, because we're sent to all different appointments. We were sent to genetics, metabolic, neurology, things like that. And so our experience, we just did, years of testing, from blood tests to spinal tap, muscle biopsies, things like that. And we never really got a formal cerebral palsy diagnosis for Turner verbally. One appointment we were at just said, I was looking at the sheet and it said cerebral palsy, and but okay, I guess that's what they think he has. We did a lot of specific genetic tests, and those all came back negative. And we had an amazing sorry, I'm not speaking very well today, neurologist that kept pushing to get the exome sequencing. And that took 5 years to get that approved, because I'm sure it's a lot cheaper now, but it was $40,000. Finally got it approved to be paid for, and got it done. And we finally got his official diagnosis in 2017 of the genetic condition. But yeah, I would just really suggest, if you suspect something is different with children, with young ones, that you approach it with kid gloves, and explain everything, explain what you're thinking, instead of just throwing out terms. And I left that appointment just feeling awful and feeling like a bad mom, and that something was wrong with my child. So that's kind of our story. I am so glad that we kept pushing to get that diagnosis, to get the exome sequencing, because now we know, and have a wonderful community, and know there's others diagnosed with the same genetic condition that Turner has. And I believe a lot of kids that are diagnosed with cerebral palsy, I would say about, and I heard this term from doctors, that it's probably about 40% diagnosed with, that they don't have cerebral palsy, they have a genetic condition. So that's kind of our story there.
Thank you, Jenni, for
You're
sharing.
welcome.
Do you want to share a little bit about how, I know you talked about the support, but how your journey changed after getting that diagnosis, after the exome?
Oh yeah, and and also with the genetic counselor we had, when he was diagnosed, we basically got a phone call. Kind of tell you that experience a little bit. A phone call, and they knew nothing about his genetic condition, and I know years later now there's obviously more known about it. And so, then I was like, well, what good is that going to do us? And then went to Children's, because we have to drive to get there, and made our appointment. And they handed me, our genetic counselor, Turner's genetic counselor, handed me a piece of paper that was a paragraph that they had obviously just gotten off the internet, of what his genetic condition meant, or what it was. And that at that time, I believe they said there was 13 diagnosed in the world. And, so you leave there thinking, well, this has gotten us nowhere. And within an hour of leaving the appointment, of course, I get online and look, and I find the KIF1A.org exists, and that there was actually about 34 diagnosed. So it was, like they didn't really do any research before our genetic appointment or try and help us connecting or anything like that. So, I really feel like all the connection we have now is because I researched and found them. But we are so thrilled that we have this community, that we know so many families. Now we're about 400 diagnosed in the world. And, that there's other kids out there like Turner. There's all different variants. So there's Turner's the only variant we know of with his specific variant on the KIF1A gene. But it's just so nice to know. And there's so much research being done for treatment and cure for KIF1A.
Wonderful.
So
The power of the internet, right?
Yes. Yes. And they're all over the world. So it's really quite something.
Awesome. Thanks for sharing that part of your story as well, because I think that sometimes people say, well, what good is it if we don't know anything, if there's no cure, if there's no, if there's nothing, no treatment known about it, but there is benefit in community. And it sounds like you've found that. Yes.
And there's benefit in knowing what it actually is. And, having that neurologist that, she really was our champion, just pushing to get it done. And we kept thinking, should we keep testing? What is it going to do for us? And it's done a lot for our family to know. It hasn't necessarily changed treatment yet, but it will when there's treatment available.
Great. And I'm going to ask you just one more question, then we'll turn it over to Erin. Because I know you and I, when we first met, we had this conversation. I've heard from many families who have first a CP diagnosis and then later a genetic diagnosis talk about the importance to them of keeping the CP diagnosis. So would you speak to that a bit about why certain families may see it that way and why some may not?
Yeah. Well, and in all reality, Turner does still have cerebral palsy because it's just brain muscle. So he has a neurological condition that his brain doesn't communicate with his body. So he really does have CP, but it's such a global term. We know why now, but for insurance purposes and getting things approved, it's helpful to have the cerebral palsy diagnosis. I found to getting things approved, the more diagnosis you have, unfortunately, you have to kind of present his worst day, his worst scenario, to get what he needs, to keep that, because, his rare genetic condition is so rare that there's not a specific diagnosis code. So cerebral palsy helps with that, to keep him, in the health he is, and get wheelchairs and all the equipment he needs.
So just to give an example of that, if a wheelchair was medical necessity and they wanted to give a code a diagnostic code for that durable medical equipment, they can't write it for the genetic condition because no code exists. So the cerebral palsy fills in that gap for the reason or the medical necessity or the need for that equipment.
Yes. And his equipment is so important that it fits and then he's safe in it. And so I've kept it. I've heard of a lot of other families trying to remove cerebral palsy, but I've kept it because I know the struggles and the battles with getting equipment approved. And then, even if it is approved, it takes probably about 6 to 8 months for a wheelchair.
Yeah. Thanks for sharing that too.
Yeah.
Great. Anything else that you'd like to share before we hand it over to Erin and then go into Q&A?
I just think for all you doctors that are on here, just to, I guess, think if you were in this family's shoes, and it's going to make me cry how difficult it is. to go down this road. It still makes me cry, even though I'm 13 years in it, and I'm seasoned and I know what's going on, but it's hard and it's scary. Yeah.
Thank you for your transparency.
Of
I appreciate your giving us a glimpse into that, because even though some of us have never walked in your shoes, just having that empathy and compassion to try to imagine what a family's going through can really go a long way, I think, on the other side, right?
Mhm.
Yeah. Thank you so much for sharing, Jenni.
Of
And
course.
we'll hand it over to hang on with us so we can ask you some more questions during
Sure.
Q&A. We'll hand it over to Aaron, and I'm gonna pin Aaron now when he comes up here on the screen. There you go, Aaron.
Hi, good afternoon to everybody. So again, I'm actually from Arizona, so I do have a very close relationship with the Mountain States. I'm a graduate of Arizona State and grew up in Phoenix. So again, Arizona and the Mountain States are very, dear to me. A little bit of background on me. I'm currently in San Diego, but I'm by trade, I'm a clinical laboratory scientist and have been directors over clinical laboratories, a master's in immunohematology, so very involved with transfusion medicine. And then also I'm a retired naval officer and served an active duty and reserves for 38 years. So I'm fortunate as a parent to have a medical background. And I think I bring that up just because I do think it helped provide some perspective with respect to advocating for a child, unlike families who don't necessarily have a medical background, being able to do that advocacy. So my son Jackson is 17. We were in. He's our third child. Our two daughters now 24 and 21. I got to see them birth in Japan and here in San Diego, and got to see what normal birthing of a child looked like. And when Jackson was born in North Carolina at Camp Lejeune, his birthing experience was very different. Everything seemed to be normal in pregnancy. There was no concerns or indications, but during the birthing process, the midwife and I noticed very quickly that the umbilical cord was wrapped around his neck 3 times. And so that just changed the pace of the delivery, as you very well can imagine. And when Jackson was finally delivered and was handed over to the pediatricians, he was not breathing. He was still bluish, and so they did stimulation and blow by, and luckily he did start to breathe. His APGARs were both normal, within normal range. He was noted to have a fractured clavicle, as well as a high white cell count, and so he was treated before discharge. And so we kind of, took home a healthy baby boy, our third child, and life kind of just moved forward. We were driving to Phoenix during the summer. I think Jackson was approximately 9 months old, maybe 8 months old. And he never cried, was very quiet. We just thought he was maybe a quiet baby. And that was until, we had our first, our well baby check at 9 months, where we did start to note that there were some developmental delays being noted. And so we were then referred to developmental pediatrics for an evaluation, and then we began to kind of reflect back on his birthing experience and what might have taken place that could have impacted his development. But so we move forward. We move through time, and he enters into therapy around 10 months. And we go through physical therapy. He's in, I think, occupational therapy, and we're really trying to work him. So my wife spent a lot of hours in the waiting room, And it wasn't until I was getting ready to deploy, I was notified I was going to be deploying in 2007. And Jackson, again, was not quite 2, and he hadn't even walked. He hadn't even walked yet. In fact, he didn't walk until he was 22 months, and that was just barely starting to walk. And so again, that was really kind of telling for us is what our life was going to be like. But we held a lot of hope in that this was just the developmental delays, and through therapies, Jackson would grow out of it. Again, not very vocal as far as word development. So we were referred to UNC Chapel Hill for evaluations, and other developmental pediatricians in the area. And my wife, after I deployed, was left, to care for 3 young children and a child that demanded a lot of attention. So it wasn't until we restationed back in San Diego in 2008. We saw our developmental pediatrician here, and he was not quite 3, and we just continued with managing him, and basically he had a PDD diagnosis, NOS, for pervasive developmental delays, and that just kind of helped, I think, qualify us for getting some additional therapies, because we did notice some maybe autistic features that were evolving. And so about 3.5, we had another appointment with our developmental pediatrician, and I asked him, like, okay, what, he just has the PDD diagnosis, he doesn't have the full autism, what is it that he's missing in the criteria? So we kind of went through that. I'm like, oh, he does this, and we kind of went through, and I think that really helped, I think, with ensuring that he could get the right additional services and qualification. And at that time, we were referred again to genetics, where again, we'd had the microarrays done and they were negative. We've had all of the fatty acid, the Krebs cycle testing, everything was normal in those early years. And even when repeated, things were normal. And then we were offered the genetic testing. Again, mind you, this is in 2008, 2009. I mean, genetics is, really still in its infancy from a diagnostics perspective. And, we maybe were a little bit hesitant about having genetic testing, I think maybe more targeted towards disease that could be present. But, we were afraid that maybe if that diagnosis occurred, that could actually impact services. So we were, at that time, we were a bit concerned, just because I think ABA services were just being approved, through insurance, and we were taking a lot of that into account. And so then, after around the same time as the autism diagnosis, we started noticing seizures. So seizures started evolving. They were drop seizures. And so we were then referred to neurology, where, again, now, we're dealing with managing seizures, and dealing with the challenges of different meds and the effects of aggression with like Topamax and that we experienced, and Keppra, before we ended up on Depakote, and we were able to successfully manage his seizures. And then we kind of continued to live life. We moved another time or two before I retired, and then we retired here in San Diego, and we were going through some autism evaluations with a neurologist, Dr. Susan Go, and we got a referral to meet with her as a neurologist. And so she did some additional x-rays. Again, prior to, MRIs CT scans were all negative, no findings on the neurological. And she asked, due to his bent gait. So now, we've been dealing with like flat feet. He's been in orthotics since he was, 1 year of age, and continues to be in orthotics with flat feet. And she asked, seeing his bent gait, have you ever had, checking for tethering? So we had additional radiology x-rays or MRIs to verify for tethering, which came back negative. And so at the same time, she had ordered genetic testing which unfortunately, being in laboratory medicine, I was able to help facilitate getting a whole exome sequencing. And from there, we got our results that showed that he had 10 mutations. All were variances of uncertain significance. And then knowing the geneticist, went and spoke with her and our genetic counselor friend that I have at the hospital, and like, hey, what do I do with all of this information? Because the neurologist wasn't quite sure what to do with the information. So meeting with the geneticist, and we need to do a trio. So my wife and I got tested, and we exhibited 9 of the 10, and there was a de novo mutation in the SYNGAP1 gene. SYNGAP1 had been identified in biology and the sciences out of Johns Hopkins and Texas Tech in 1998, and the first patients weren't diagnosed until 2008. And so we were, again, Jackson now is 10 in 2015. So, we were about the 76th patient diagnosed in the world. And so we're like, well, what do we do? I mean, we have an answer on what's causing all of his challenges. And, I got involved in a foundation that really was advocating for patients. But, when we got the genetic diagnosis and she saw that the tethering, was normal, she's like, well, Jackson has spastic diplegia cerebral palsy. And so that was really very interesting and surprising, because I looked in the literature and I was looking for, cerebral palsy as part of the SYNGAP1, list of, clinical indications, and it wasn't there. And so we got the cerebral palsy diagnosis at 10 years of age. But then I started doing research and doing a lot of reading on genetics and cerebral palsy, and found a number of different articles that really did suggest that there were genetic indications for cerebral palsy, which again, I think we often think of the typical, birthing injury or head injury that might occur. That's classic of cerebral palsy. And since that time, I've really been an advocate of, evaluating and talking with our family members within the SYNGAP1 community about and listening to their story and whether they have a cerebral palsy diagnosis. Currently, SYNGAP1 related intellectual disability, as was pointed out, is we are actually very fortunate to have an IDC-10 code. It's F78.A1, so Foxtrot 78.alpha1. And this is really, we're one of the very few of the rare genetic disorders that actually have an ICD-10 code. And we've been advocating as a foundation, the SYNGAP Research Fund, to one of our parents is a physician and has really been advocating with the CDC on developing how other genetic disorders can get, because we think that's so important. But, we've been working really hard. And then, in the community is, talking amongst the families. We actually have a number of patients that actually are wheelchair bound. They have upper use of mobility of their hands, not a problem, but they have a very difficult time of using their lower extremities. And we actually have a lot of our children that actually do have a lot of mobility challenges and have the bent gait. As you might see a picture of Jackson with the bent gait. But that's how he walks. He walks with a bent gait and a sort of a crouch gait sort of stance all of the time. I mean, if you think about those workouts where you have to stand against the wall in the bent position, that's him all day long. And I've always been very concerned about his mobility as he grows and gets bigger. And that continues to be something that we monitor. He does use a wheelchair for longer distances, but he definitely can move. And what's amazing is he can move pretty fast, even with his mobility challenges when he is motivated. So again, we really begin to work through our community but most of our community doesn't have a diagnosis of cerebral palsy, very few of them. And all of those children that are in a wheelchair, none of them have a cerebral palsy diagnosis. And so it made me wonder, what's the definition of cerebral palsy? And I'll say specifically spastic diplegia, cerebral palsy, because I think that fits most of our community. What is it about not getting the diagnosis? Is it the perception of because it's genetic, this child has a genetic disorder? Is it because when you do an office visit, you really don't get a great clinical presentation? And so we actually do work really hard, with our families to talk about cerebral palsy and to talk with your physicians about, would it be appropriate based on the mobility challenges, the stands, and actually get pictures and video to be able to show. Because again, when you're in front of your physician, your provider, it's a very quick. And I think being able to give a complete picture using videos and recordings can really help provide a clear clinical picture on what might be happening with the child. And so we really do encourage that. And then we've actually recently started a digital natural history study with Citizen, which is through Invitae, and they collect all the medical records. And we just went through as they've categorized all of the comorbidities of SYNGAP1. We've noticed that cerebral palsy is starting to show in a few of the kids, and largely within the missense children, which is slightly different than the nonsense mutation. So again, we are starting to work towards differentiating, looking at a mutation that's missense versus a nonsense, and what the challenge is, because many of the patients that are in our community actually are missense that have the mobility challenges. And so does some.
Right there, Aaron, could you explain the difference between missense and nonsense if people are not familiar with those terminologies? Not to put you on the spot, but just generally.
Yeah. So the missense mutation is a point mutation in the gene where in the nucleotides, transcribing for the codon for the amino acid is one of those codons change. The nucleotide changes the amino acid, and in Jackson's case, it's from a glycine to a serine, but the proteins remains fully intact. Where a nonsense mutation, truncated, would mean that there's maybe where you get the stop codon automatically from a mutation, or you have a frame shift, insertion, deletion that results in a termination of that protein, and then it's being truncated. So you only have one good copy of the gene. And so, which is, I think, very important from a clinical perspective, because as we move towards treatments and therapies, the difference of the strategies for us, because we're loss of function of that protein. So we're haploinsufficient, and we're very similar to other disorders like XTXBP1, DLG4. I mean, it's amazing. It's always amazing the alphabet soup that comes with the genes, and specifically in the neurological space. But we're the therapies that are evolving, as you might see, was just published for Rett syndrome. And in fact, Jackson, when he was seen by looking at the data, his medical record in full from when he was at UNC Chapel Hill, at 1 year of age, he was suspected of a genetic disorder. He was suspected of a male's version of Rett. and his developmental pediatrician and her differential diagnosis was like, there might be a genetic component to this. So, again, 8 years later, from 1 or 9 years later to when he's 10, we get a genetic diagnosis when he was suspected early on of having genetic doses. Was just amazing to see that evolution in the medical record and in the journey that he actually did have it. Would we have known what to do with a SYNGAP1 mutation if we had done that? Because again, yeah, right, $40,000 for a whole genome or exome back in those days. He would have been one of the first patients, and nobody really would have known because there really hadn't been that clinical correlation. So it is amazing in today's clinical medicine that genetics can play such an integral part in so many aspects of care, and especially in pediatric neural development, and development, and being a differential diagnosis is genetics really a part of this? And then when you're seeing these comorbidities, when you see the development of cerebral palsy along with the autism and maybe the seizures, that you're looking at a very complex neurodevelopmental disorder that could really be genetic related. And we work very closely with the Simons Foundation on us helping with research and again collecting survey data to help help clarify the clinical picture of the SYNGAP1 related intellectual disability. And again, we're lucky to have that ICD-10 code. But in treatment, we're looking, with Dravet syndrome, having an ASO antisense oligonucleotide treatment. We're in a really, I think, pivotal time for genetic disorders having opportunities for gene therapies or to have an opportunity to really help with fix the clinical mechanisms that's in error, whether you're talking Angelman syndrome, which is in a lot of clinical trials currently. Rett syndrome just got published a treatment this weekend. And again, there's a number of clinical trials with biopharma. So, now getting identifying if genetics is a part of a complex clinical picture is so very important, more than it is ever. And I think, again, primary care physicians play such an important part of identifying that complexity and obviously making those referrals in helping that diagnostic journey for complex patients. So, and so
I actually have the picture. If you want me to share it here, if you wanted to comment at all on, I know you were referring before about the gate.
Yeah, so this is, if you've ever been to San Diego and you've been to SeaWorld, this is the entrance of SeaWorld. And you can see Jackson, if you did a really close up, you would see he's got his AFO orthotics on, and you can see his bent gait, and he actually walks in that bent gait all the time, and he stands in that position all the time. But he'll actually go on all those crazy roller coasters at SeaWorld. So he's quite the thrill seeker. But we try to help with his mobility by, we've been offered to use a walker in treatments. We have tried Botox with orthopedics and trying to, get the muscles to relax. And those treatments have not been successful. We've done the standees to try to help, with, getting to stand up more to elongate his muscles. And I think that muscle plasticity is just really very, very difficult to treat. And again, like I mentioned earlier, as I think I often have worried about his mobility and, being on medications where you gain weight and just how that would impact his mobility. We've chosen not to use a walker because we want him to really be independent and try to move. But I do think there are patients that can definitely benefit from that. And we do see that in our patient population. across the world.
Thanks for sharing that, Erin. Any last words of wisdom that you'd like to share before we go into Q&A, just for primary care providers and pediatricians that are working with families that might have a CP, a possible genetic underlying condition?
Yeah, I think that the power of genetics today is so valuable in helping identify root causes to what the clinical picture, what's happening clinically with the patient. And those, and I think cerebral palsy definitely in the and when you see neurodevelopmental disorders, then I think oftentimes that, the child might be in, might not like to get out because the autism, or, other clinical indications like the autism or whatever, being able to get a really clear clinical picture, right? I think when we were talking, we talked about, making sure that the shoes come off, because I think, looking at the feet and are they flat? And I think orthopedic, the AFOs, the orthotics are so important because the feet are so important to the whole alignment of the body, and be able to identify those early. Because I remember early on in our diagnosis, I would share pictures of Jackson with the flat feet, and all of a sudden everybody was sharing pictures of their kids' feet on Facebook, and you could see a lot of where a very common clinical features were in that way. And so I do think it's important that to recognize the power of genetics, and the power of genetics in the diagnosing of neurodevelopmental disorders that can include definitely, in these brain and these brain genes, the possibility of cerebral palsy being it, and aligning that cerebral palsy, and I'll say spastic diplegia, aligning to, the definition of what it means to have cerebral palsy, outside of what the traditional diagnostic criteria would be, or events would be for the diagnosis.
Thank you so much. That's great way to segue into some Q&A here. I do see that Jenny put in the chat, and I'm just going to read this so it's captured on the recording for those of you who are watching this afterwards. She just says, if you would like to learn more about Turner and our family, please feel free to reach out, and you can reach out to Mountain States and we can connect you. And if you would like to learn more about KIF 1A associated neurological disorders, visit KIF1A.org. The founder of our organization's daughter that lives with CAND and currently doing an ASO trial for K1F1A with N. Lorem. Did I say that right? So that's Jenny has that in the chat there. So I would love to open it up for questions from our audience. We do have a group joining today. I don't know if our speakers saw this. I just want to welcome them from Paso del Norte Children's from El Paso, Texas, and they have their Help Me Grow team on with us today. So welcome to them. They are providing navigation for families who have children ages 0 to 8, specifically regarding development. And they also are offering support and training to pediatric providers in the El Paso, Texas area to support families. So just wanted to welcome them and just ask if anyone who is on the call would like to unmute their line or type it in the chat, and I can read it to our guest today. And I'm going to take the pin off so everybody can see Erin and Jenny back here. So while everybody's thinking of questions, would anybody like to unmute their line and ask a question to our family guests today? If not, I will ask them one as everybody else is thinking. One of the reasons we do these family conversations is really to bring a perspective of, as you said earlier, Jenny, of walking in a family's shoes and trying to get an idea of how pediatricians, how primary care providers can really come alongside families and help. So looking back on both of your journeys, could you just highlight maybe one thing that you think could have been done differently that would have been more helpful or more supportive to your family now that you are much further down the path. So looking back to those early days, I think you both have kind of alluded to some of those, but if you had to kind of give one gem or one pearl of advice on what you think could be done differently, if anyone on this call maybe even has a patient on their caseload now that they're thinking of listening to your stories.
I can go first. I mean, I think, for Jackson, when we diagnosed him at 10, we have had patients that have gone through surgical procedures to try to elongate the muscles, from that plasticity. And I think doing that in an older child is very difficult. We actually have a family where their child just had gone through that surgery. And so I do think, trying to identify it early, can that early identification help with, treatments that are easier to manage when a child is, 40 pounds than a child, who's, over 100 pounds. And so, I mean, I think early diagnosis can kind of help with the course of potential treatment options. I think would be one observation that I would have that would have helped with an earlier diagnosis.
Great. Thanks for sharing that, Erin. How about you, Jenni? Do you have any thoughts on that? I know you alluded to this a little bit.
Yeah, I mean, I kind of said trying to be in the family's shoes, but I think maybe some more education on non-typical children. Don't ever use the word normal. I hate that word. I do not like that word. And I think just don't ever throw out diagnosis when in the end, yes, Turner did get a cerebral palsy diagnosis, but to a new mom in a typical doctor appointment, don't just say, what you think it could be. Yeah. And
Thank you.
I am so thankful that we finally got to Children's Hospital in Denver, because Turner has some of the best care in the world. We have, he's got more than a handful of specialists that he sees, and has had spinal fusion surgery, hip surgeries, foot surgery, and luckily we did get there early. We probably could have gotten there a little bit earlier, but we're very thankful to have all of his amazing specialists.
Great. Thanks, Jenni. And just a follow-up question to that, I know Erin shared quite a bit about his son and mobility and the gait and options. I know when you and I talked earlier, you shared a little bit about Turner's mobility. So would you like to share with the group a little bit about that?
So Turner's never walked independently on his own. He's used a wheelchair since he got his first wheelchair when he was about 3. And he uses a stander, and we did a huge fundraiser last year and raised $35,000 and got Turner a Trexo robot that he walks in. And that's what that picture that you first posted was, of him walking in his robot. And it's amazing. He loves it so much. And the weight bearing for him, I have, the physical attributes that we get from it are amazing, but what he loves it. I think first and foremost, he just loves it. He loves standing and walking and being at the same level with his peers. And we're very lucky. Turner's happy almost all the time. He doesn't speak, but he communicates a lot without saying a word. But when he's walking, he's just so excited. Loves it so much.
Thanks for sharing that. I thought that was the device you were talking about in the picture. So thanks for clarifying that. Great. Well, I want to give some opportunity. I know everybody else has been on mute for a really long time. So is there anyone else that's on the call today that's joined us that just has any questions for Erin or Jenni that they'd like to ask? Feel free to just unmute your line and go ahead and ask. Or if you are not in a place where, I see Laura popped on. Go ahead, Laura.
I'll pop on really quick. Jenni and Erin, I just want to thank you all. This aspect of of being providers is really important for us to come on and listen to the experiences of families, even though we're not. So for our role in Help Me Grow, we, we're a community-based nonprofit. Our team is made up of different disciplines, and our care coordinators, what their role is to, be that resource for families. But the component where we do provider training is to try our best to get into pediatric practices, do training on developmental screening, on training on engaging with families to help practices to be able to integrate that more, especially as they're engaging with families, and for Help Me Grow to be kind of that value added benefit for this community and engagement and collaboration. And so for us to hear your story, to then take that with us when we go into these pediatric practices and be mindful of the experience you had, so that we can hopefully try and help, ensure that that is not the experience for another family going into that. And so, I do appreciate the opportunity to be a part of, of the network and get this learning and hear your stories, because, we do carry that with us in the work that we're trying to do in the community. So thank you both.
No, I mean, can I just say, we appreciate, navigating to get like genetic testing approved because of all, right, is not always easy, right? I think, so we appreciate the effort and the teamwork that it takes for both the patient and the clinicians to work together to kind of make the justification for why genetic testing can be so important to the clinical picture. And I do think that we have seen healthcare disparities, within our own genetic disorder. And I think this is probably true of all the rare diseases that we see. And to your point of being in community-based, rural-based, what we see in underdiagnosis in African Americans and in the Hispanic populations. And so I do think that it's important to know that we can do better in identifying, recognizing genetic disorders in the cause of neurodevelopmental intellectual disability. SYNGAP is about we've been identified through a UK study to be about 0.5 to 2% of the intellectual disability population. So that's a pretty big number when you get down to it. And we're really underdiagnosed in the United States. And I think that's probably true of a lot of genetic disorders where intellectual disability, mobility issues are apparent in the clinical picture, that genetics is probably part of that. We've also been working with a company, Probably Genetics, that will do if you do a quick small survey for free, it'll actually through AI identify whether a patient would be a candidate for genetic testing, and then we'll offer free genetic testing for a patient through Probably Genetics. And again, I think the industry is working really hard to help ease down what patients could benefit through questionnaires and through AI, whether they would be a good candidate for genetic testing. And it doesn't cost anything, to do that work.
Thanks, Aaron. Thanks, Laura, for being on with your Help Me Grow team today. We appreciate it. And just another mention, I see Jamie's on, I think, from Texas, and Lourdes works closely with Laura's team. We have genetic navigators that Mountain States has put into place, one in each of our states, who are families themselves who have navigated genetics for their own loved ones. So they know some of the ins and outs of some of the things we've talked about today, like insurance and equipment and appeals and denials for genetic testing. And so that program is available to any families in our region for free, our Genetic Navigator program. And so I just wanted to mention that because we're really trying to help with that navigation piece of all the questions that maybe the genetics provider or the primary care provider can't answer at the moment, because they have all their time spent on the clinical piece of it, which is where we need their time spent on. But some of those other things like navigating 504 plans and school stuff and insurance stuff, that maybe our navigators can help point in the right direction. So just wanted to mention that as well. So we have about 5 minutes left. Is there anyone else on the call that would like to ask a question or comment on the topic we're wrapping up today, which is cerebral palsy and genetics. Anyone else? All right, I don't see anyone else popping on here, but I did want to just remind all of our clinics that joined us today. This is the 4th month of our CP module. So we started off with a newsletter, which is archived on our website. That 2nd month, we had a great webinar, which is still available for CME credit on CP by our professor down in Arizona. And the 3rd month, we mailed you some things to your clinic about cerebral palsy, a great decision-making tool or a question tool that families could use. So hopefully everybody got their packages in the mail. And then this 4th month is our family conversation. So all of this is archived in our Time for Genetics library on our website. So if you've missed any of those components about this topic, you can go back and review those or look at those links. We just appreciate so much Aaron and Jenny being here today and sharing their stories with us. Any parting thoughts as we wrap up from our guest speakers?
I just think it's so wonderful that you guys are doing this, trying to help families, and that the organizations exist. I wish I would have had both of you in the early stages to help navigate. And I think another big thing is just communication and just educating families as much as you can with processes. I feel lucky that I'm a researcher. I'm not, by career, but I research everything and I dig and dig until I find, I get the best returner and work really hard at it. But I feel for families that don't do that and don't know how to, keep pushing until you get the answers or you get what your child needs. And I think it's so wonderful that you guys exist to help families navigate things.
Yeah,
Well,
and I
thank
wanted
you.
to say, the
Go
Western
ahead, Aaron.
State. Yeah, I just want to thank just the opportunity to, allow us as parents to provide our perspective on our medical journey, and what we as parents are dealing with on a day-to-day basis, and that partnership with our medical team is so very, very important. And again, there's foundations. Again, I am part of the board with SYNGAPResearchFund.org. And again, I think the patient population continue to expand and evolve to really help families once they've been diagnosed to kind of partner with them through that journey. And I think so. Again, I think it's important that patient groups are working hard to complement the medical teams and what they're doing. And again, what I find fascinating with your next topic on the testing for prenatal testing, I think you're right, is coming up.
Newborn screening. Yeah, newborn screening. Yep.
There's the recent expansion of some of that for genetic disorders, and SYNGAP1 is a part of that panel. So again, so it's befitting to see that journey continue, and you'll see more and more of SYNGAP1. So I promise you, if you haven't seen it yet, you will see SYNGAP1 a patient in your future. Thank you.
You will see KIP1A patients as well.
Yeah.
We're getting KIP1A on the newborn screening panel, and it's not a matter of if, it's just when there will be treatment and cure for KIP1A.
Yeah.
Thank you both for introducing those letters to us today. if those who on the call haven't heard them before, thank you for giving us a story, not just alphabet soup, right? Really, it's not just about those letters of the gene. It's about your precious children too and your families. So thank you for giving us that perspective today. And with that, I will go ahead and close us out for the day, and just thank you both Aaron and Jenny once again for your time, and thank you to all the clinicians and providers that joined us for your time today. Thank you so very much. Talk to you all later. Have a good rest of your week.
Bye.
Bye-bye.